Now that we have discussed the mechanisms of hypoxemia, the use of PEEP and CPAP to manage hypoxemia, it's time to look at modes of ventilation that are commonly used to manage acute hypoxic respiratory failure, and they are the pressure control modes. This first tutorial will look at the primary principles of pressure control ventilation. Tutorial 21, Pressure Control Modes of Ventilation. This tutorial is Pressure Control and its Primary Principles, Part 1. Welcome back. Previously in this course we looked at volume control modes of ventilation, and I discussed the different modes of volume control and the advantages and disadvantages of those modes. I then looked at pressure support ventilation and the ins and outs of using pressure support. We then started looking at respiratory failure, we looked at ventilatory failure and oxygenation failure, and we covered hypoxemia in quite significant detail. And I followed this by discussing oxygen therapy, including high-flow oxygen therapy, principally delivered through nasal cannulae. I then moved on to talk about PEEP and CPAP and the indications for using them. This time we're going to talk about pressure control. I'm going to start with a discussion about the terminology that's used, because sometimes that's a little bit confusing. I'm going to talk about driving pressures and inspiratory times, volume variability, and inspiratory rise times. But first, let's start with terminology. Well, pressure control refers to a group of modes of ventilation, and always present in these modes is an airway pressure limit. I'm going to call that the pressure limit, the PL, that is targeted. And when you target an airway pressure, the tidal volume will always vary. It doesn't matter if the manufacturer of the ventilator claims that it can guarantee a tidal volume with that pressure limit. It always varies. It can't not vary because the patient changes position. The chest wall compliance changes in all kinds of different ways. So airway pressure limit is targeted. The breath does not end when the pressure limit is reached because the breath is always time cycled. So the ventilator generates a flow of gas, it reaches the pressure limit, and it holds that gas in the lungs until you tell the ventilator to cycle to expiration. So it's time cycled, and the flow pattern must always decelerate. The term inspiratory pressure refers to the pressure above PEEP or atmospheric, if you haven't got PEEP on, that the operator dials up on the ventilator. For example, we may make the following settings: a respiratory rate of 15, an inspiratory pressure of 15 centimeters of water, and a PEEP of 5 centimeters of water. The pressure limit, the PL, is the inspiratory pressure plus the PEEP in centimeters of water. And that means that the pressure limit is 15 plus 5, which equals 20 centimeters of water. The driving pressure, though, is slightly different. This refers to the actual pressure gradient for gas flow that occurs during inspiration. For controlled mechanical ventilation, for pressure control, this is the inspiratory pressure minus PEEP plus Auto-PEEP. For example, if the patient is on the following settings: an IP of 15, a PEEP of 5, and the Auto-PEEP is 3 centimeters of water, then the driving pressure is 12 centimeters of water. Just to reiterate, for controlled breaths, the driving pressure is the inspiratory pressure minus the PEEP plus the Auto-PEEP. So the Auto-PEEP reduces the driving pressure. However, when there is an assisted or spontaneous breath, the whole thing becomes more complicated because the driving pressure now must incorporate that negative pressure that's generated inside the thorax. So the driving pressure is the inspiratory pressure plus the negative inspiratory pressure minus the PEEP plus the Auto-PEEP. And that's a little bit head-wrecking, and I'll cover that again later on. The other things that you do need to be aware of, the terminology, is the inspiratory time, the I time. I'm going to put it down as the TI, time for inspiration, and the expiratory time, the TEXP. And the TI, inspiratory time, refers to the inspiratory time in seconds. It is the duration of inspiration that is dialed up by the operator. The breath will last for this duration unless the patient pressure cycles the ventilator by exhaling or coughing, for example. The expiratory time refers to the expiratory time in seconds, that the TEXP, and this can be set on some modes of ventilation, particularly bilevel pressure control modes. Now let's start this tutorial proper with a clinical scenario. You're called to the ICU and your patient is Frank, he's 59 and has acute hypoxic respiratory failure. Frank was admitted 4 days ago. He has a history of smoking and alcohol abuse. He has bilateral infiltrates in his chest x-ray. Initially, he was treated with high-flow nasal oxygen, but his rapid shallow breathing persisted. He was then treated with CPAP, but the PF ratio, that's the PaO2 divided by FiO2 ratio, continued to fall, so he was intubated. Now the question arises, well, what strategy for mechanical ventilation do you want to use here? Are you going to use volume control? Are you going to use pressure control? And if you're going to use pressure control, does it really matter what mode of pressure control you're going to use? Now you'll recall that the human thorax is a pressure controlled apparatus. We generate negative pressure within our pleura. This generates negative pressure within the alveoli, and that results in gas flowing along the negative pressure gradient into the alveoli. The tidal volume is proportional to the magnitude of the negative pleural pressure, and it is biologically variable. The purpose of positive pressure ventilation is to breathe for the patient who cannot or will not breathe, or whose inspiratory effort is inadequate to maintain homeostasis. That's why you need to build a breath on top of CPAP. You also need to assist the patient's spontaneous breaths to reduce the workload of breathing. So regardless of whether the problem is central, peripheral, or due to reduced compliance or increased resistance, you would think that pressure control, which essentially mirrors what we normally do, will be a perfect mode of ventilation. If someone develops acute hypoxic respiratory failure that's not responding to conventional therapy, we give them neuromuscular blockers. So in the setting of Frank being intubated and ventilated, because he's not breathing, there is no biological variability. So this is a strike against using pressure control. No matter what mode of pressure control you use at this stage, once he's paralyzed, they're all the same, whether you use pressure assist control, SIMV pressure control, or bilevel pressure control. They're all the same because they're essentially cycling from a PEEP level to an inspiratory pressure level and back again. The difference in the pressure control modes really reflects how the spontaneous or assisted breath is handled. So for the rest of this tutorial, I'm going to assume, for most of it anyway, that the patient is unable to breathe spontaneously. So this is pressure control, and you'll note that the driving pressure, or the inspiratory pressure, on the ventilator is 15 centimeters of water. The rate is 15, the PEEP is 5, the I time is 1.2 seconds, the control breath is triggered by time. The gas is blended and the breath is ready to be delivered by the bellows or piston. So let's just trigger the ventilator. And gas passes along the inspiratory tubing, and in this case into the endotracheal tube. The lungs inflate and the diaphragm and the chest wall move down and outwards. The thoracic pump is entirely passive. The breath will register as a control breath on the ventilator, hence the C that you see on the smaller screen. And because it's pressure control, the inspiratory flow always decelerates. Inspiration ends at the end of the inspiratory time, and expiration is by elastic recoil. On the waveform screen, note the decelerating flow pattern that continues to the zero flow baseline and that square-shaped pressure waveform that looks like a top hat. Now let's talk about the driving pressure. All pressure-limited modes have the following in common. The tidal volumes are always variable. And they're variable because the inspiratory ramp varies from breath to breath. I've already mentioned the driving pressure, but on top of that you have the issue of spontaneous breaths or controlled breaths. You have changes in the inspiratory time, you have changes in the patient position, you have changes in respiratory system compliance, and changes in respiratory system resistance. And all of these things will have impacts on the tidal volume, not from breath to breath necessarily, but from hour to hour. I'm just going to introduce a term to you now that I find helpful, and that is the inspiratory ramp. And it really refers to the pressure gradient at the beginning of the breath. It is identical to the driving pressure. But why it's important is because the ramp is greatest at the beginning of the breath and it progressively falls off as the breath continues. In this illustration, we have a pressure limit of 20 and a PEEP of 5. Therefore, the IP is 15. There's no auto-PEEP, so when the ventilator cycles, the driving pressure is 15 centimeters of water and the resulting tidal volume is 450 mils. Now let's add in some auto-PEEP. I've added 3 centimeters of water of auto-PEEP to be exact. Now we have a total PEEP of 8 centimeters of water. The inspiratory pressure is still 15 centimeters of the water because the ventilator does not account for auto-PEEP. When the ventilator cycles, the ramp is less steep and the driving pressure is 12 centimeters of water, resulting in a tidal volume that is lower than you would expect, 370 mils. Core thing to understand about pressure limited modes of ventilation is that flow always decelerates. The ventilator cycles from zero flow to peak flow, and we will discuss how rapidly that occurs later. But because the inspiratory pressure ramp progressively reduces as gas enters the alveoli because the airway pressure rises, flow slows down and eventually stops as the plateau pressure is reached. That pressure is held until the inspiratory time elapses and expiration occurs. This is known as time cycling. Let's move on to talk about positioning and mechanics and why the patient position will impact the tidal volumes in pressure control ventilation. This is a cartoon of a gender-neutral person who we will call Charlie. Just to explain the components here, we have the lungs, the heart, a chest-abdominal wall interface, abdominal contents, fat and organs and bowel, and an endotracheal tube. It's important to understand that the abdominal contents can compress the diaphragmatic surface of the lungs and that the heart sits on the left lower lobe bronchus and can compress it. So here we have Charlie standing erect and on a ventilator. We're using pressure control with an inspiratory pressure of 15 and a PEEP of 5. And in this position, the tidal volume is 500 mils. Somewhere in a parallel universe, there's another Charlie who is on volume control ventilation, and that Charlie is receiving 450 mils. Let's see what happens to Charlie's tidal volumes as we move them around in the bed and into different positions. If we place Charlie in a sitting position, there is a slight upward movement in the abdominal contents, and this causes a little bit of compression of the lungs, reducing the tidal volume for the same settings to 480 mils. Meanwhile, volume control Charlie still getting 450 mils. In the typical semi-recumbent position that we nurse patients in the ICU, there is slightly more abdominal compression of the thorax and slightly more cardiac compression because the heart compresses backwards, resulting in a fall in the tidal volume to 450 mils. So that's quite a substantial drop in the tidal volume just lying the patient in the semi-recumbent position. Now Charlie is lying supine, and you can see that there is a posterior cephalad displacement of the diaphragm causing significant compression and airway closure to the posterior dorsal segments of the lungs. The left lower lobe bronchus is being compressed by the heart. The tidal volume has now dropped to 400 mils. Again, volume control Charlie in the parallel universe is still getting 450 mils tidal volume. In the Trendelenburg position that you might use for placing central lines or during laparoscopic surgery, there is significant displacement of the abdominal contents into the thorax. Worse, of course, if the patient is obese, collapsing the pressure-controlled tidal volume down to 350 mils. Again, if you're using volume control, the tidal volume will be unchanged, but the airway pressure would significantly increase. So you can see that by changing patient positioning in conventional pressure control ventilation is associated with fairly dramatic changes in tidal volume. Certainly something you don't want to see in situations where CO2 control is critical, for example in patients who have traumatic brain injury. The other issue to consider is loss of chest wall compliance due to problems within the thorax, pleural effusions, pneumothorax, mediastinal masses, or extrathoracic problems, in particular abdominal compartment syndrome caused by, for example, bowel edema. And in this situation, all this compression results in a significant fall off in the tidal volumes. So that's low chest wall compliance. And something that happens sometimes quite insidiously in a patient. A patient's bowel may start to become quite distended, for example, from severe constipation that might happen over several hours. And you might leave the patient on a certain level of pressure control, but over time the tidal volume just drifts down, 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 down. It's something to be aware of. The other thing to consider is bronchospasm. Bronchospasm is associated with increased airway resistance. There is significantly greater driving pressure required to achieve tidal ventilation. There is also a problem with significant auto-PEEP. Pressure control ventilation is really good if the patient is breathing spontaneously because flow demand can be met quite well because of the inspiratory ramp, but long inspiratory times may result in catastrophic auto-PEEP and cardiovascular collapse, and sudden breakage of the spasm, sudden reversal, may result in huge tidal volumes and potentially ventilator-induced lung injury. So just to summarize this section, chest and abdominal wall mechanics have significant impact on tidal volume during pressure control ventilation. Increased airway resistance may result in low tidal volumes for high driving pressure and significant auto-PEEP. If tight control of tidal volumes and PaCO2 is required and the patient is being moved around a lot, consideration should be given to using volume control or volume guaranteed pressure control. As I've previously mentioned, all pressure control modes are time cycled. And in general, you can set two of the following three items. You can set the inspiratory time, the respiratory rate, and the expiratory time. So for example, you set the inspiratory time and the respiratory rate, the expiratory time and the respiratory rate, or the inspiratory time and the expiratory time. And I'll give you a few examples of how this can be done. If you dial up an inspiratory time of 2 seconds and a respiratory rate of 15, what is the expiratory time? Think about this for a second. Well, the answer here is 2 seconds. 2 by 15 equals 30. 60 minus 30 equals 30. Divide that by 15 and you get 2. If you dial up a TI, an inspiratory time of 1.5 seconds, and an expiratory time of 3.5 seconds, what is the respiratory rate? Again, 3.5 and 1.5 is 5 seconds. Divide 60 by 5 and you get 12 breaths per minute. Finally, if you dial up an expiratory time of 4 seconds and a respiratory rate of 10, what is the inspiratory time? Well, this is 10 by 4, which is 40, 60 minus 40 divided by 10, and that equals 2 seconds. If the inspiratory time exceeds the expiratory time, or put another way, if the I to E ratio is less than 1:1, this is called inverse ratio ventilation. It's an advanced ventilatory strategy that is used in severe hypoxic respiratory failure. In the next tutorial, I'll explain why we might do that. We need to talk about respiratory rate and expiratory time. If you go to the operating room and look at a patient who's on a mechanical ventilator in the OR, and see how it's been set up by the anesthesiologist. Most of the time you'll note that they use an I/E ratio for setting the inspiratory time and expiratory time, and that ratio is usually 1:2 or 1:3. And there's a major advantage to this approach in that those ratios are fixed over a wide range of respiratory rates, so that as the anesthesiologist changes the rate during the operation, sometimes, for example, the CO2 goes up because there's carbon dioxide being insufflated into the peritoneum during a laparoscopic case, the inspiratory and expiratory times basically match each other. However, on ICU ventilators that deliver pressure control, they're usually set up to fix in an inspiratory time on those pressure limited modes, and this is potentially quite problematic. For example, if the respiratory rate is 15 breaths per minute and the inspiratory time is 1.5 seconds, the expiratory time is 2.5 seconds. That's a 4-second cycle. Now, the patient may have a high PaCO2, or they may have a pH of 7 or 7.1, and you want to blow off some acid, and you turn up the respiratory rate. So if the rate is increased in these settings up to 25 breaths per minute, the inspiratory time remains exactly the same, but the expiratory time falls to less than 1 second, and you have inadvertently put the patient on inverse ratio ventilation. Because of the short expiratory time and the loss of control, the patient will start to build up a lot of Auto-PEEP, and the tidal volumes will fall and the PaCO2 will go up, and there will be a temptation to increase the respiratory rate further. In general, the respiratory rate in pressure control should be limited to fewer than 20 breaths per minute. And the reason for this is that at higher breath rates, expiration is time limited by definition, and this leads to gas trapping at end expiration and auto-PEEP. And auto-PEEP is potentially hugely problematic in pressure control ventilation. This is a screen printout of a patient who's on pressure control ventilation with a rapid respiratory rate, and you can see if you follow the flow waveform, you can identify auto-PEEP there. Remember, if you suspect auto-PEEP is present, you must do an expiratory hold maneuver on the pressure waveform. Pressure control and children. There are hospitals all over the world every day in which children are placed in mechanical ventilators, both in the operating room and in the ICU. And children come in all shapes and sizes, varying from neonates to teenagers who are practically adults. And this makes mechanical ventilation challenging because tidal volumes need to be calculated out for their ideal body weight. And there is considerably less wiggle room for children than for adults because small apparent differences in tidal volume, maybe 20 to 50 mils, may result in massive lung expansion differences. Moreover, ventilators that are shared between pediatric and adult patients risk volume trauma when the adult-associated default setting is accidentally delivered. And this can happen in the operating room when in the middle of an operating list there may be a child and the anesthesiologist just flips on the ventilator when they're intubated and adult settings are generated. So it's sometimes better to use a completely different mode than you normally use for children and just automatically switch to that mode. And that's the real beauty of pressure control, because pressure control modes are inherently safe, as total respiratory system compliance limits tidal excursion during normal inspiratory pressure ranges. For example, an inspiratory pressure of 10 centimeters of water may deliver 7 mils per kilo to an adult, but will also deliver 7 mils per kilo to a child, even though the volumes are significantly different. The adult may get 450 mils, the child may only get 125 mils. Further, uncuffed endotracheal tubes remain popular for use with children. However, there is always a cuff leak. And modern mechanical ventilators are able to generate enormous flow that will overcome the cuff leak and pressurize the airway. If you give volume control to a child with a uncuffed tube, a lot of the tidal volume will just leak out and the exhale tidal volume will be much lower than planned. And that's one of the real values of using pressure control. And that's why, for example, BiPAP machines use pressure support or pressure control modes, because they can overcome the leak by continuously giving pressure to the airway. Initial flow and the inspiratory rise time. It's widely believed that peak and plateau pressures are identical in pressure controlled ventilation. This is the objective, but it's not always the case, because all pressure limited modes require initial flow adjustments. Gas flows from high pressure to low pressure, and the greater the pressure gradient, the greater the ramp, the more rapid the flow. However, in general, higher inspiratory pressures are given to patients with more diseased lungs because their lungs are non-compliant. And the lower the compliance, the more likely it is that the airway will overpressurize with maldistribution of gas in the parenchyma if very rapid flow rates are delivered. On the surface, one would assume that when a ventilator cycles to inspiration in pressure control, the flow of gas is so rapid that the patient's airway pressure goes straight up to the plateau goal. But of course, that is not the case. The piston in the ventilator has to drive the flow of gas to that pressure limit, and it is possible to apply a set of buffers to the gas flow to control that initial rate. This is known as the inspiratory rise time, and all pressure limited ventilators have this setting, although sometimes it may be a little bit hidden. But it's how we control that initial flow to stop overpressurization. The rise time is the time that it takes to achieve the inspiratory pressure limit, the PL. It is used in controlled and assistant breathing in pressure limited modes of ventilation, not in volume controlled modes. In controlled ventilation, a rapid rise time that's too fast for the patient may lead to pressure spiking and pressure cycling of the ventilator to exhalation. Now, in the patient who's breathing themselves, if the patient has high flow demands, then a shorter rise time will be more comfortable. However, this may lead to overshoot and more rapid flow cycling of the ventilator, for example, in pressure support ventilation. Too slow a rise time increases inspiratory time and may cause dysynchrony and increase the work of breathing. Let's look at a couple of ventilators. This is the Puritan Bennett 980 ventilator, and the rise time is controlled on this ventilator by a specific setting that gives you a percentage, and you can find this on the screen, and I'll show you that later on. And on this particular setting, we have it at 70%. What does that actually mean? Well, the percentage is the percentage time it takes to reach 95% of the target pressure. That's the PL. The higher the number, the shorter the time to reach the target. So it varies from 1% to 100%. 70% reaches the target twice as fast as 35%. The lowest setting is 1, and a rise time setting of 1 produces a pressure trajectory reaching 75% of the inspiratory pressure, the PL, in 2 seconds, or 2/3 of the inspiratory time, whichever is shortest. The Servo I has a slightly better system in my view, and the rise time is a percentage of the respiratory cycle in control modes. So it's the inspiratory time plus the expiratory time, and the range is 0% to 20%, shortest to longest. So that's 20% of the total time in inspiration and expiration. The Draeger Evita events do the rise time. They don't call it rise time, they call it the slope, but it's the rise time in seconds. The minimum time is 2 seconds and the maximum time is 0 seconds. And the factory setting is 0.2 seconds. You can see the settings here, the FiO2, the PEEP, the inspiratory pressure, and the slope, and that's what they call the rise time. And when you see that number 0.2, that means that the inspiratory rise time is 0.2 seconds. So this is a really, really tidy and accurate way of controlling that. And this is my favorite of all the rise time settings. Now, this is a picture that I showed you in the tutorial on pressure support ventilation. The rise time has been set at 70%, which is very fast, but remember that this is a spontaneously breathing patient who may have a high flow demand. The patient triggers the ventilator and the target pressure is reached very quickly. The orange triangle represents the steepness of the rise time. In pressure support, of course, the more rapidly the lung is inflated, the higher the peak flow, the more rapidly the ventilator cycles off to expiration. In this case, you will see that the rise time has been set at 30%. The rate at which the peak flow is reached is much, much slower, and you can see the orange triangle. The breath will be necessarily longer, but there is a risk of inspiratory dysynchrony. Now, let's have a look at Frank, who has these non-compliant lungs, and he's a driving pressure of 15 centimeters of water, and we've set his rise time at 70%. And let's see what happens. You'll notice that there is a spike in the pressure waveform, and the waveform isn't flat, it's kind of slanting downwards. And the reason for this is that it's overpressurized the airway. So there's a spike in pressure above the pressure limit, and everything has got very, very unstable, and the breath has lost its stability. So it never kind of sits comfortably at the target pressure level. So this is really a rise time that's too fast, and the big risk here is that the ventilator will cycle because of the high pressure in the airway, and the breath won't be delivered, and everything goes clunk, 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 clunk. How do we resolve this problem? Remember that our goal is to deliver gas to the airway, and this is pressure targeted and volume variable. So we want to get up to that airway pressure level, and we want to hold the gas within the lungs for long enough to ensure adequate ventilation of diseased lung units. As a consequence, we want to see that nice flat topped pressure waveform. Our patient is not breathing spontaneously, so we don't need rapid gas inflow to meet demand. We're going to reduce that rise time to 50%, and let's see what happens. Inflow is much slower than before, but you can see that that slow inflow has resulted in a nice flat top pressure waveform, and that's what we've been targeting. And the rise time is medium, so you can see the orange triangle there. Will give you an idea of how slow the flow goes from 0 up to peak flow. Finally, you really do have to have a strategy for using the rise time. In general, 50% is perfectly fine for the vast majority of patients. You may choose a faster rise time, for example, 70%, if your patient is demanding a lot of flow, particularly in pressure support ventilation, but sometimes in pressure control. That's fine, but the lungs need to be fairly well compliant. For poorly compliant lungs, such as Frank here, we really can't give them that fast flow because it just bounces off the lungs. It's like spraying a wall with a garden hose. It just sprays back on top of you. As a consequence, the rise times should be in the region of about 50% for patients with poorly compliant lungs, sometimes a little bit lower, certainly not less than 30%. Finally, I just thought I'd mention a few of the problems associated with pressure control. When compliance is rapidly deteriorating, tidal ventilation may fall progressively. And what I'm trying to point out here is that lung disease tends to be progressive. When a patient comes into the ICU and is intubated, they're often moderately hypoxemic, and they're on the way down when you put the tube in. Often the lung disease gets worse. And so a patient may be intubated with a compliance of 40 mils per centimeter of water, but it might drop down to 20 mils per centimeter of water over the next 18 to 24 hours. If you're using pressure controlled ventilation, you need to be really careful about the tidal volumes, because if the compliance is falling, the tidal volumes will fall progressively for the same driving pressures. This is also true of airway resistance. When airway resistance changes rapidly, tidal ventilation may increase dramatically or decrease dramatically, and resistance does change in patients in the ICU. Now, I've already mentioned bronchospasm, and that happens all right, but in fact, airway resistance is way more than that, because Patients generate a lot of secretions in their airways. They do generate airway plugs. There may be some bleeding in the airways. There's crud in there. Sometimes the tube kinks. And as a consequence, the higher the resistance, the more driving pressure that is required to inflate the alveoli. And so even the patient turning their head and kinking the tube will cause a dramatic fall off in the tidal volume. And as a consequence, it's imperative that if you put a patient on pressure controlled ventilation, you meticulously follow their tidal volumes. You need to pay a lot of attention to these patients. And if you're distracted by putting patients up on continuous renal replacement therapy or drawing up drugs or changing syringes, you may miss a catastrophic fall off in the patient's tidal ventilation. The other issue is you need to be extraordinarily careful when you change the respiratory rate in someone on pressure control who has a set inspiratory time, because this may cause a huge buildup of Auto-PEEP. And the reason why I say this is because the expiratory time drops as the respiratory rate goes up. Let's review this tutorial. This was Primary Principles of Pressure Controlled Ventilation, Part 1. I started by discussing the use of the correct terminology when describing pressure control. Particularly, I separated out the inspiratory pressure and the driving pressure as different concepts. I also discussed the pressure ramp and why tidal volumes can vary enormously depending on the patient's position, lung compliance, lung resistance, etc. I discussed how you can set the inspiratory time and the expiratory time and the impact of changes in respiratory rate on different times. Finally, I discussed the inspiratory rise time and its impact on pressure controlled ventilation. Next time, we're going to do Primary Principles of Pressure Control Part 2, and I'm going to show you why pressure control is a good ventilation strategy for patients with acute hypoxic respiratory failure. We look at phasic ventilation perfusion mismatch. This time, during inspiration, I'll explain the concept of mean airway pressure and why it's so important, and how to prolong inspiration in pressure control and what happens when you do so. But I'll also show you that you can increase mean airway pressure in volume control ventilation, and I'll compare and contrast the different strategies. I'll see you then, and I guarantee you'll learn something. So that was Primary Principles of Pressure Control Part 1. Next time, in Part 2, we look at the mean airway pressure. If you're enjoying these tutorials, don't forget to subscribe at YouTube or follow me at ccmtutorials.org.